Hey everybody, you are listening to The Poison Lab, and I have an episode I'm really excited to share with you. Something I think everyone in the tox community is really going to find valuable, especially if you've had a busy schedule lately. If you didn't have a chance to peruse the 312 published research abstracts from some of the best and brightest in the field of clinical toxicology that was presented at the 2022 North American Congress of Clinical Toxicology in San Francisco, or even if you did, come along with us on this episode. Myself and a special expert panel are going to do a high-yield review of some of the most clinically impactful abstracts that were published at the conference this year. We're going to be joined by Dr. Grant Comstock and Dr. Dan McCabe, both emergency medicine physicians and medical toxicologists with fantastic training and expertise, as well as Dr. Natalia Farrell, an emergency medicine PharmD and ABAT clinical toxicologist like myself, who's got a wealth of experience. They're going to be helping me break down the clinical implications of 15 very important abstracts that were presented this year. We'll be talking about the paradigm shift in calcium channel blocker toxicity with increasing amlodipine overdoses and their generally unique shock states that can be predominantly vasoplegic, and the data that discusses how the clinical care for these patients are different. We'll be discussing clinical outcomes in patients who are identified to have Xylazine in their system during overdose, as well as a number of other important topics, like new limitations in our brain death testing. If you want to see all the abstracts we're going to discuss, check out the show notes, where they're all listed within their individual categories. In total, we'll cover 15 important or interesting research abstracts. So I hope you can tune in. For longtime listeners of the show, you might notice that Toxo's voice has changed a little bit. Don't worry, there'll be more to come on that, but I don't think it'll be too distracting for you. Finally, before we jump in, I wanted to say thank you to all of the hardworking authors who designed intelligent protocols, abstracted data, and worked hard to discover things in the field of toxicology. We did our best throughout the show to give credit to the authors of the abstract, but we are but flawed humans. Everyone worked hard on this, so I'm sorry if we missed your name. I really encourage everyone to check out the PDF of all of the published NACCT research abstracts that's listed in the show notes, so you can see every person who was involved in making this research possible. Okay, we've got a lot of ground to cover today. Let's dive in. Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and I have a really fun and exciting episode today, one that I think a lot of people are going to find valuable. If you didn't have time to cruise through the 312 published abstracts from the North American Congress of Clinical Toxicology, well, we have a special episode for you, because in this episode, we're going to review some of the most meaningful research that was presented this year by the best and brightest in toxicology at the North American Congress of Clinical Toxicology. So I have sort of handpicked my favorite abstracts that I read at NACCT this year, ones that I thought had the highest clinical implications to the things that I see day to day. And I have invited an expert panel to come in and discuss the implications of this research. So we have three really great special guests with us today, and I'm going to let them introduce themselves, their background, and where they're practicing now. Dr. Comstock, would you like to start?
Yeah, happy to. So my name is Grant Comstock. Completed my residency in emergency medicine at the Denver Health, and then did a fellowship in medical toxicology at the Rocky Mountain Poison and Drug Safety Fellowship. I finished that last year, and I'm now new faculty in emergency medicine and medical toxicology with Ryan at MCW in Wisconsin. And happy to be here.
And Dr. McCabe, would you like to go next?
Absolutely. Thanks, Ryan. My name's Dan McCabe. I'm an emergency physician and medical toxicologist at the University of Iowa. I trained in emergency medicine at Cook County in Chicago, and then did my fellowship of medical toxicology up in Minnesota. And now I am the director of the Division of Medical Toxicology at the University of Iowa and the associate medical director of the Poison Center, in addition to working in the emergency department.
And for any of our listeners with a keen ear That would be the same Dr. McCabe from our episode 16 regarding Phenibut that we discussed, and he has graciously agreed to join our show today. So thank you, Dr. McCabe. And last but not least, a guest I'm very excited to have on the show, Dr. Natalia Farrell-Farndy.
Thanks for having me, Ryan. My name is Natalia Farrell. I am a clinical toxicologist and emergency medicine pharmacist at Boston Medical Center. I did my PGY1, PGY2 emergency medicine pharmacy residency training at Boston Medical Center. Afterwards, I completed a clinical toxicology fellowship at the Georgia Poison Center. I've been a board certified toxicologist for almost 8 years now, and have practiced at Rhode Island Hospital and Boston Medical Center during that time.
Thank you all so much for joining today. We're going to be reviewing approximately 15, hopefully, if we have time, maybe up to 17 of the abstracts that were published and presented at the North American Congress of Clinical Toxicology in San Francisco, California in 2022. So this is about the top 5 to 6% of abstracts. So this will hopefully be a high yield review of some of the more interesting research that was presented this year. Disclaimer, there might have been some research that was very relevant to you that wasn't relevant to me. So I won't say that this is entirely comprehensive. I did leave out a fair amount of snakebite literature. I know there's a hot debate amongst Anavip and Crofab out there in the world right now. And it is very interesting, but we're not touching so much on the envenomation. So these are more things that I know I routinely run into, and I think they kind of change practice. So the large groups of abstracts we're going to be talking about today, there's 4 main categories. And here's Toxa with a breakdown of what those are.
Category 1, Amlodipine Vasoplegia. Category 2, Xylazine. Category 3, Case reports with terrifying clinical implications. And Category 4, Comparative evidence, prognostication, and triage.
And you're here for a high yield episode, so we'll cut the chit chat. Without further ado,
Category 1, Amlodipine Vasoplegia. Abstract 1, Vasodilation in patients with calcium channel blocker poisoning treated with high-dose insulin. A comparison of amlodipine versus non-dihydropyridines.
This one is from our Minnesota Poison Center and a Minnesota Toxicology group, John Cole, Sam Lee, Nate Kunzler, and Travis Olives. This was a 2-year retrospective study of high-dose insulin and calcium channel blocker poisoning at a single poison center. The team hypothesized that amlodipine treated with high-dose insulin had more vasodilation compared to verapamil or diltiazem. They had 18 patients with amlodipine and 15 with verapamil or diltiazem, and they compared the total amount of vasopressors and high-dose insulin that was needed. What they found was the median infusion rate for the amlodipine group was 10 units per kilo per hour compared to 5 units per kilo per hour for the verapamil or diltiazem group. Use of rescue methylene blue was more common in the amlodipine group than in the non-dihydropyridine group, and epinephrine dosing was higher in the amlodipine group compared to non-dihydropyridines. So it appeared that you needed higher doses of high-dose insulin, higher doses of vasopressors, and more rescue agents when looking at amlodipine versus verapamil or diltiazem. Does any of this surprise you guys? What do you make of this?
This study is super fascinating and bringing, I think, a lot of very important attention to amlodipine toxicity. The thing that stands out to me is in that top line where you look at the rate, the high-dose insulin infusion rates were double for the amlodipine as opposed to the non-dihydropyridines. And that, I mean, mechanistically is kind of a fascinating finding because it's so profoundly vasodilatory, amlodipine. Then you think about insulin, it's really an inodilator. And so mechanistically, you can look at that and say, is this really a preferred agent in this setting? And to see double the rates of insulin for amlodipine as compared to the non-dihydropyridines, where mechanistically that makes a ton of sense. That really is a standout finding to me. And I wonder how that impacts, the kind of downstream manifestations of needing more methylene blue or needing higher doses of your vasopressors and things to that effect. And so one of the takeaways I get from this is, kind of looking at really the interplay between high-dose insulin and the dihydropyridine calcium channel blockers and saying, is this an agent that has a role? And if it has a role, kind of where in your own kind of medical algorithm does it sit? And I'll say personally, I don't consider insulin until I've got a probe on the chest, and a consideration of kind of naming that shock. Am I going to call this cardiogenic shock, or am I going to call it vasoplegic shock? And if it's seeming like the EF is grossly normal or hyperdynamic, I'm not again personally. Of course, there's a lot of room for conversation in this. But I don't reach for insulin. I'm reaching for vasopressors in that scenario. And so I think this really is going to bring a lot of attention and probably some very some good discussion, probably some good science as to kind of exactly what that role is for insulin in the world of amlodipine toxicity.
Agents like amlodipine get forgotten about a little bit or think it's not as bad as diltiazem or verapamil. But mechanistically, amlodipine has a greater vasodilation, and it also may release like nitric oxide. So it makes sense that high-dose insulin would be less efficacious and that we may use adjunct therapies like methylene blue a little bit more frequently than with diltiazem and verapamil.
I think that was beautifully put. For so long, we've lumped together calcium channel blockers as a single toxin, but truly we have two different potential presentations. You have the non-dihydropyridines, which are both cardiac poisons and they cause vasodilation. And then you have amlodipine or the dihydropyridines, which will cause vasodilatory shock and not always a cardiogenic shock. And how do we decide what dose of high-dose insulin you need? Well, you start it, and if they're not getting better, you increase the dose. And since we know that high-dose insulin from this same group, Cole and colleagues, in 2013, they did a study on propranolol poisoned pigs and demonstrated beautifully that high-dose insulin, as you increase your dose, it lowers systemic vascular resistance and it increases cardiac output. In amlodipine, you might already have a low systemic vascular resistance, high output state, or you could have a low cardiac output, low systemic vascular resistance state. So I think this brings to light we probably need to do a more patient-specific assessment of the shock phenotype before jumping to high-dose insulin, because the high-dose insulin, at least based off this, dialing up these doses and needing more of these refractory agents, it might not always be the right choice for specifically amlodipine.
Agreed.
And in truth, everything we're saying here is in line with what the recently published adult calcium channel blocker evidence-based guidelines recommend. They actually say right in there now, only reach for high-dose insulin if there's evidence of myocardial dysfunction. But then as a lower grade recommendation in there, it says, well, if everything else isn't working, you could consider trying it, even if there isn't myocardial dysfunction. So it is it feels like we're trying to get away from just broadly using it, but it's only a recent development. And I think that's not something that we were, as a tox community, doing a great job of differentiating.
Yeah, and I feel like we need to also point out a little bit that this group, very intelligent researchers and clinicians, they also published in 2018 in American Journal of Emergency Medicine how they've been implementing it as a poison center safely high-dose insulin, and this is their poison center recommendations when they're implementing high-dose insulin, but they recommend titrating to improvement of shock, and as people have already alluded to multiple times already, the differentiation of what type of shock becomes very important. Not all shock states are the same, and I feel like this abstract that they're putting out and the subsequent papers will probably change a lot of our practice to even push us more towards doing the probe, like Grant said.
Abstract 2. Amlodipine anxiety, a 10-year review of amlodipine-associated fatalities.
So it looks like this is a paper from Chicago, Dr. Bush and Dr. Bryant. For their population, they had a 10-year regional Illinois Poison Center review of amlodipines fatalities, and they were looking, at single agent and multi-agent exposures. Their outcomes that they found were a dramatic shift in the overdoses starting in 2018, and it was implicated in more deaths at their poison center than all other calcium channel blockers together. So they had a total of 37 deaths. 98% of which required or received vasopressors, 80% got high-dose insulin, 35% interestingly got intralipid, less than 10% got methylene blue, and then all of them did not receive ECMO.
Okay, yeah, so I kind of chose this one for two reasons. Number one, amlodipine is far and away, probably just due to its prevalence in the community, one of the most common calcium channel blocker overdoses. And so we're seeing it way more. And here in this center, they said, amlodipine is the calcium channel blocker overdose causing the most deaths in their state. And it's just a great segue. So we just kind of talked about, okay, amlodipine, often a vasoplegic shock. Well, we have our therapies. We use pressors, high-dose insulin. It's definitely being used. But what do you do when all of that is failing? Oftentimes ECMO gets thought of. And the traditional role for ECMO is cardiogenic shock. It increases blood flow, right? You program it to a flow rate. We know blood pressure is equal to our, the shear force between our cardiac output and our systemic vascular resistance. ECMO doesn't increase your systemic vascular resistance. And these patients are in a SVR depleted shock. So it is kind of confusing to me. It almost seems like ECMO wouldn't be warranted in an amlodipine overdose if it's not cardiogenic. But it does happen a lot. I mean, sometimes we'll get a call at the poison center about a patient who's already cannulated for ECMO from an amlodipine overdose, sometimes before they've even gotten near high doses of vasopressors. And I don't know that I always agree that it's the right therapy for that shock, because just like we're talking about, it doesn't really make sense in my, simple mental model of the physiologic basis of this shock. And despite it not making a lot of sense, when I look at this study, I see all these patients got high-dose insulin, vasopressors, all these other things, but they all died and none of them got ECMO. It just raises a question to me. Would they have done better with ECMO? This is kind of one of those conundrums for me.
I agree with that word conundrum because I'm not sure what to do with it. It's interesting data, but I would like to know what is percentage of patients got amlodipine toxic that didn't die, and how many patients were amlodipine toxic that got ECMO. And also the reality of the world that we all practice in is the vast majority of patients aren't in ECMO centers anyway. And are they stable enough to be transferred someplace else? So I feel like this is a good starting point to other conversations. And just don't really know how this changes my conundrum of the amlodipine toxicity.
I would also offer that I'm not 100% sure where to move forward with this. I guess a question, Ryan, I'm reviewing the notes from the abstract, and a question that crosses my mind is, are there data in regard to amlodipine toxic patients who got ECMO and did well, or is this just a look at those who died and a commentary that none of them received ECMO?
They did not report out on, and this is what we need to look at, what are the outcomes in patients who have amlodipine overdoses and get ECMO? What is the rate of survival in that scenario? And I guess I'll just point out, I don't think the authors were trying to assess the utility of ECMO in amlodipine overdose. It was just a piece of information that was in there. And sometimes when I read through other studies, despite what their hypothesis is, I see interesting data that seems relevant. And that's kind of why I brought this up. This isn't a study designed to look at the comparative efficacy of ECMO.
Right.
And I think kind of just what's unique here is, as a group, we're kind of starting to emerge with the fact that, yes, there's different phenotypes of shock with this drug class overdose. You can have vasoplegic or cardiogenic. Do they need to be managed differently? In theory, vasoplegic would be managed differently. I think I brought this up because I'm just touching on really what is the role of ECMO in vasoplegic shocks. And I don't know what to do with this study, but the next one in our group kind of helps us answer that question.
Abstract 3. Extracorporeal membrane oxygenation utilization for vasoplegic shock due to pediatric toxic ingestions.
So this was a retrospective case review of the institutional ECMO database for pediatric patients who received VA ECMO for vasoplegic shock related to poisonings. Shock was defined as hypotension requiring vasopressor support with the absence of significant myocardial dysfunction. 10 patients received VA ECMO support. The overall survival rate was 80%. However, there was a 50% complication rate, with 5 patients having complications in total, 3 of them being strokes, 1 cannula dislodgement, and 1 patient had an upper GI bleed and compartment syndrome. So There was an 80% survival rate, but a high complication rate at 50%. So the role of ECMO in vasoplegic shock without respiratory failure is still not clear. It may also pose additional risks to the patient.
For me, this does not answer the question, and if anything, provides negative data. When we say vasoplegic shock and having a survival rate of 80%, so it's hard to know what we mean by vasoplegic shock. What are my pressure requirements? What is my toxin of interest? How ill is that patient? If this is, I've got multiple patients on, limb ischemia inducing large doses of vasopressors, and granted, you shouldn't have that in vasoplegic shock, but if you've got really just massive doses and these patients are absolutely refractory, then sure, that's a population where you expect a poor survival rate. But I would wager that we deal with a lot of shock and toxicology and some degree of vasoplegic shock or otherwise, and our survival rate is probably, this is a super broad strokes comment and maybe not founded in enough evidence, but 80% doesn't sound like that amazing of a survival rate to me, where I'm looking at, wow, what an amazing intervention. And then I see these complications, and I think these are catastrophic. A stroke in a pediatric patient, a compartment syndrome, the tube dislodgement, all of these things are big deals. And I think it's hard to know specifically what to make until you know the granularity about the agents and about what they mean by vasoplegic shock with pressor infusion rates and just how refractory to supportive care that they've been. And if it really kind of bears out that these are patients that you would not expect a survival rate of 80%, then okay, maybe, I stand down and maybe there's a role. But until that, I'm not sure that I look at this and say, wow, that survival rate of 80% is A, attributable to the ECMO, and B, worth the complications that are coming along with that pretty significant invasive intervention. So I don't know that this answers the question for me, and it certainly does not push me further down the road of wanting to offer ECMO for a pathology that I don't think mechanistically makes sense for using it.
Yeah, I agree with what was just said. I feel like this kind of pushes me away from vasoplegic shock states for VA ECMO. But were these patients inherently sicker to the point that they were higher risk for catastrophic issues at baseline? But 50% of complications, very significant complications, is extremely high. So it'd be great if we could somehow theoretically have a similar paper on the survival rate for patients that have similar cardiogenic or vasoplegic shock states at amlodipine and see what their survival rate is. Because if their survival rate is anywhere near 80%, I think a lot of us would then say we shouldn't be using ECMO.
Right. We almost need the denominator from that Illinois study. How many of those vasoplegic shocks died without, out of all those who did have vasoplegic shock? Unfortunately, they only looked at fatalities, so it's hard to suss anything out. These are two studies that feel like they're very quasi-associated, but they're sort of two ships passing in the night in terms of matching an outcome with each other. For reference, another, of course, Minnesota group study on ECMO and poisonings found that the overall survival for poisoning in ECMO was 70%, but it was higher amongst those who had cardiovascular poison. So you're most likely to survive. Those who do best on ECMO are cardiovascular poisonings as opposed to metabolic or hematologic poisonings. Personally, I think this just all points to the fact that in the coming years, there needs to be potentially a little bit more discussion and a little bit more light shined on ECMO. Has always been thought of for refractory cardiovascular collapse, but is it all collapse, or are there different collapses where it's necessary? If it's collapse because it's vasoplegia, is there another route we should go because there are high complication rates as opposed to collapse due to dysfunctioning myocardium?
I feel like this is a good source of conversation that we should be having as the toxicologists with our ECMO teams. At most places, the final decision on this is the ECMO provider and our perfusionist to do this or not. And if you haven't had those conversations ahead of time on when we're going to pull the trigger, so to speak, to do ECMO, then it becomes some patients might be put on that shouldn't, or vice versa.
My institution only recently in the last year started to do ECMO cases. So I know our perfusionists are very selective about what cases they will take, and they're really taking cases that from the mechanistic standpoint have the greatest likelihood of having success with ECMO.
I think that's really such a good point that you bring up, Dan and Natalia. There seems to be quite a bit of variability in the gung-ho-ness of cannulation amongst many different institutions. So when it comes to these high resource, potentially highly invasive and, debatable, at least, conversational efficacy interventions, the time to have the conversation about who is a good candidate is probably not when they're crashing right in front of you, and probably feeling out that data with studies like this and your ECMO team long beforehand can go a long way in determining who the right candidates are. I guess, one thing to consider, I guess, in some of these vasoplegic shocks, if you are like maxed out on every pressor and you're on high dose insulin and all these things, if you crank your output up high enough, I mean, in theory, that does increase your blood pressure. So maybe, if your SVR is 0.1 and you turn your cardiac output to 30, you'll get something out of it, I guess. But I don't know. Well, I think that was a great discussion. Perhaps much heat, but little light was generated. But I do appreciate getting to ping some of these ideas off much brighter than myself. So thank you guys for that. I think we're going to go on to our next category here, which is something pertinent to many, especially off in the northeastern part of the United States.
Category 2, Xylazine. Abstract 4. Tranq dope opioid overdose. Clinical outcomes for emergency department patients with illicit opioid overdose adulterated with Xylazine.
This abstract was from Dr. Love and some of the toxic group. This was a multi-center prospective cohort. It was essentially adults with a suspected opioid overdose who presented to one of 9 participating emergency departments in the United States over a 1-year time period. And they used waste serum from the patient, and these were analyzed by liquid chromatography, quadruple time of flight, mass spec for illicit opioids, different fentanyl analogs, adulterants, and xylazine. And essentially what they did was they compared patients that had opioids in their system to xylazine plus an opioid. They ended up having a total of 321 patients that were analyzed. 90 of them had xylazine in their system versus 231 did not have xylazine in their system, and they had opioids or more of the analogs in their system. 80% of the patients from each group, about the same, received naloxone. And after controlling for multiple confounders, including age, sex, race, prior psychiatric history, blood pressure, and how much naloxone they received, they found that patients with xylazine in their system had a significantly lower possibility of having a cardiac arrest, so with the odds ratio of 0.3, and coma. The xylazine, I guess the overarching question of this whole study, this abstract, is the xylazine cause decreased mental status without actually decreasing your respiratory drive, which may theoretically lead to less cardiac arrest.
Yeah, I thought this was a very interesting study. Fantastic. Some of the only kind of controlled comparative data of our people who are being exposed to Tranq, which is xylazine and fentanyl, versus just fentanyl. And lo and behold, we're all worried about xylazine. It has a lot of complications, but in this study, it actually seems like the patients did better with xylazine because they have less cardiac arrest and less coma. Those aren't the only 2 outcomes in the world that matter, but I thought that was kind of interesting, and I'm not sure why.
A question that we would like to know would be, when is this coma? Was this a coma at time of arrival? Was this coma before they got naloxone, after they got naloxone? And also, does it be phenomenal if we had quantitative data on this? Is this fentanyl being cut with xylazine? So in lieu of having an opioid, you're having xylazine, or is that totally negligent?
That could definitely impact some of the different findings that these authors found compared to primarily the Philadelphia area's findings. There's a lot of xylazine in the fentanyl illicit heroin supply in the Philadelphia area, and I believe it was from one of the MMWRs from the CDC that said it's been associated with increasing opioid-related fatalities, and that's the detection of xylazine as well as the quantity of xylazine detected in samples has been increasing. In Massachusetts, where I am, in supplies sent to Massachusetts drug supply data stream found over the last year that it went from being a very low incidence, low quantity kind of cutting agent to now it's being very much detected and at much higher ratios to now be considered a high cutting agent. Anecdotally, I don't think I'm seeing less fatalities with potential xylazine fentanyl combinations. I find with these cases, we tend to not have the adequate response to naloxone because naloxone is not going to reverse the additive CNS and potentially respiratory depression from xylazine. So we tend to intubate a lot more patients.
It's just such an unexpected takeaway from this study. You're right, Ryan. It's a really thoughtful study. They have comparator groups and have data that are not generally readily available with liquid chromatography data. And so all of that is very compelling, but in the absence of knowing if there is an acute exposure or knowing the quantity of the exposure or what other fentanylogs were potentially present, there's just so many other confounders that I think potentially contribute to such surprising results that I look at this and I want to say, cool, Xylazine seems protective, huzzah. But that is just it's just so contrary to how I could possibly process this. I don't know that I look at this and I think I've got a takeaway. And that's absolutely no commentary on the study or on the authors. It's such a surprising study that I would just beg for more granularity and data. And I honestly, I don't even know necessarily the quantitative assays would answer that question. And fentanyl has got such profound lipid distribution that really concentrations don't correlate well with clinical phenotype. So we can talk quantitative stuff all day. I would love to know kind of further detail about other fentanyl that were present, or if there's other historical data about if they have any comment about known use of xylazine from the patient themselves, if they've got any commentary about the actual content of the drug supply that's out there in a lot of these fentanyl studies. And so there's a lot of other, I think, pieces of this puzzle that are missing that it would provide a lot more understanding of these data. But it's a super interesting study, and I think so much of this will inform really the management of the emergent opioid toxidrome when they come into the emergency department as xylazine becomes more prevalent, because those toxidromes overlap so profoundly, and to make the gigundous leap and extension of xylazine to clonidine, and does clonidine response to naloxone. That has been one of the things that floats around in my mind is the presence of these alpha-2 agonists have something to do with these reports of these massive requirements of naloxone that are popping up here and there. And does this kind of contribute to that? So, does the xylazine change outcome? Does it change our response? But ultimately, I am not sure what to do with this. It's an interesting start.
Grant, you actually reminded me of something I thought about when I was reading this abstract and then forgot to bring up here. This is all of the patients that made it to the ED, correct? So this means that theoretically could be that more patients didn't make it to ED and they made it to a medical examiner instead. So I would love if this group or a group with similar resources could actually maybe do a secondary study of looking at the percentage of cases at the medical examiner for their qualitative analysis, because it's all living patients in this. And it's obviously a well thought out study, but that becomes kind of a limitation also.
Right. I think maybe we're suffering from the wrong denominator once again. This could be a little bit of sampling bias. Maybe xylazine Tranq dope is so potent, most people do die. And if you don't, it's because you didn't take enough, so you got to the ED. That's who knows really what's going on. But at least from a pragmatic standpoint, these are the people you will see in practice. And it does seem that they did better for who knows what reason. Potentially, maybe it causes you to become unconscious faster, so you stop using, but it protects the respiratory function. But that doesn't seem likely to me. Yeah, I agree. I think there's a lot more to know, and we probably need another comparative sample of who's getting autopsied, how many people are showing up at the ME. Some great things they do in this. This was 9 different EDs, though, so it's a great representative population. And it's essentially blinded to the investigators. You have no idea what they were exposed to until way later when the confirmatory testing comes back. So you're treating each patient the same. And that's kind of cool. I wish I could have seen data on how much naloxone each group needed. That would have been really interesting. Well, more to come on that, I'm sure, as xylazine continues to rifle through America.
Category 3, Case reports with terrifying clinical implications. Abstract 5. Recovery after polydrug overdose despite blood flow imaging demonstrating no brain perfusion.
I'm actually going to read this one because it shook me to my core. Recovery after polydrug overdose despite blood flow imaging demonstrating no brain perfusion. I'm going to let that sink in for just a moment. This is a 42-year-old woman who was found unresponsive with empty bottles of tizanidine, zopiclone, and hydroxyzine nearby. She was intubated because she had no gag reflex. She was unresponsive to painful stimuli and having seizures approximately every 30 minutes. She was then sedated with continuous IV midazolam and propofol. She was given sodium bicarbonate for a wide QRS. She was put on norepinephrine for hypotension and had her seizures treated with levetiracetam. On hospital day 2, her sedation was turned off for 6 hours, but then restarted. Okay. On hospital day 3, the patient was sedated with midazolam and propofol. She had no corneal, cough, or gag reflexes and was taken to nuclear medicine for a brain blood flow scan. The scan showed no dynamic perfusion in the cerebral vascular system over 3 minutes and had delayed frontal and lateral images that showed no tracer activity within the brain, but some uptake into the nasal region. And then on hospital day 4, she had her sedation changed to dexmedetomidine, and she actually slowly started waking up. She began to follow simple commands. Her EEG showed moderate encephalopathy, and she had progressive neurologic improvement until on hospital day 8, the patient transferred to behavioral health in good condition. Actually, that was on hospital day 11. But the point here, this patient who took a polysubstance ingestion with some GABA and anticholinergic activity and was sedated on propofol as well as midazolam, had a nuclear medicine scan that showed no brain perfusion. And terrifyingly, I think that's sort of what a lot of people use as the final step before declaring brain death in a toxin overdose, and this patient still woke up. So I think there's certainly some confounding here, given that the patient was on all these sedatives when she went through the brain scan. But you know, what do you guys think about this?
This is such a terrifying case. And I feel like this is always these types of things when we have patients that we believe are probably neurologically devastated. I feel like this is always in the background, in the back of all of our minds as toxicologists. Is this a brain death mimic or not? The one thing that, and Ryan, you may have seen it or not, I wish I had. I don't feel like there was an EEG described prior to the perfusion scan. The only one I believe, and I believe is spoken about, is the encephalopathy after the perfusion scan. I would like to know if there was an EEG done before that. I personally, my own personal practice, I don't use EEGs a whole lot to change my practice on if a patient that's seasoned, that's a tox patient, most of the time, they read it as toxic encephalopathy, something like that. But in a patient that is, we're trying to figure out if it's a brain death mimic or not, if there's any kind of waveforms, those would be pushing me more towards not complete brain death. But the perfusion scan showing brain death is just terrifying.
Right. So for context for listeners, in case they're not familiar, so ACMT has a guideline for how to determine brain death in overdose, or more so, it's a position statement they put out in 2017 for how to interpret the neurology evidence-based guidelines for declaring brain death in the setting of overdose. You can go check them out online, but this is kind of an abridged summary. The neurology guidelines say before you declare brain death, you need to identify approximate and irreversible cause of brain death. Well, having a drug on board is a reversible cause, and thus you really can't declare brain death doing brain death testing if a drug is still on board. So the ACMT guidelines say do your absolute best using, testing or a really focused history to figure out what drug the patient could be on and wait at least 5 half-lives of that drug before doing brain death testing. But obviously, we know that is so limited in toxicology for so many reasons. Overdoses prolong your half-life. If you take a huge dose of drug, even, waiting 5 half-lives, you might still have a good amount of drug left, even if it's only 3% of the drug that's left. And most of the time, we're not going to confirm what drug it is anyways. So now you're waiting 5 half-lives of 5 therapeutic half-lives, not the same as an overdose half-life, of a drug that we're not even sure they took. So we basically never know if the drug is on board or not when doing brain death testing clinically. I mean, it just frequently that's the case. So the ACMT guidelines say, essentially, since you can never really do brain death testing accurately if you don't know if the drug's on board or not, you should do a cerebral perfusion scan as the final step before declaring brain death. There's a bunch of different scans people can do. You can check out the guidelines. They say things like a cerebral angiography, transcranial Doppler, single photon emission CT. They say all these things, and they say, currently there's no evidence that has been found that a drug or toxin could be the sole cause of, an absent cerebral blood flow scan. And it seems unlikely that a drug or toxin could do that. So I think for most people, in most practices, this is the final step that we do before declaring brain death. Because of all of the other weak tools that we have, this is sort of the last thing that we can try. And it appears, at least based off of this study, that this test is flawed as well.
And what was also really scary for me too is when they did the scan, the patient was receiving midazolam 4 milligrams an hour and propofol 20 mg per kg per minute. Those are pretty low doses in the grand scheme of sedatives. So the fact that the perfusion scan showed kind of no flow really makes me wonder how much tizanidine, hydroxyzine, and the zolpidem the patient did take, because it must have been a massive amount to have a brain death mimic when the sedation that was being provided by the hospital with midazolam and propofol was at relatively low doses.
Well, honestly, should they have even been on sedation when they went for brain scan is a question that I have. I mean, if we're trying to rule out brain death, and maybe they took it off and it's just not clarified well in this case report.
They took it off, but the patients started seizing again. So it was started back up again to help with the epilepsy control.
Ah, that would make more sense. Okay.
I have nothing smart to add. This is terrifying. And you can't keep somebody intubated and sedated forever, waiting for them to clear. I think we have guidance available. We have a lot of weak tools. And this, it's obviously unacceptable if you ever take somebody to donation for before they're truly brain dead. And so I don't, other than sleepless nights, I don't have a whole lot of things that will change based on this, because it's hard to change practice on a case report, but boy, that's a scary one. So I would love to read the case report in more detail and see if there's other things that maybe I can latch onto as some sort of comfort. But based on the way we've described it, it's a fairly thorough investigation and evaluation. It's still turn the other direction. I do wonder why the patient, did the patient just start waking up that rapidly after a brain scan that there was no time to take them to organ donation, or were there other things going on with them that were other signs of life that maybe aren't presented, here that we're talking about? And so maybe there's more than meets the eye, but if there's not, it is alarming.
You really bring up an interesting point there. This patient happened to wait around long enough after the brain scan to wake up. But most patients, this is the final step before they go for, organ harvest or we withdraw supportive cares. So, I mean, no guideline ever said this was the gold standard. It's just sort of the last step, the last tool that we have. And it sort of makes sense that there aren't many cases reporting that the tool has failed, because we do the test and then we never keep looking to find out if, they improve despite their cerebral blood flow scan.
And am I the only one that these 3 medications that this person reportedly took, those are not on my short list of brain death mimics? So that's also the secondary, very, very terrifying part of this case report.
Right.
Is that, am I supposed to expand my differential for brain death mimics? At this point, I haven't, but this is not on my short list.
I haven't added them to my list either. I think I would have been more convinced to do so if there were levels that were reported for this patient to, one, confirm that these were the substances that were actually ingested and contributed to the picture and not just the empty bottles, found at the scene. And if the levels were, off the charts, then I think I'd be, more on board with it. But without having that quantitative evidence, I don't think I'll be adding either of these three drugs to my list of brain death mimics.
So I do think there is one thing that this sort of changes or reinforces for me. Frequently in toxicology, we discuss that testing doesn't always change care, but in patients who don't have any other, catastrophic brain injury findings on imaging, and they're doing brain death testing, it might be valuable to test in order to ensure that drug is no longer in the system so that you can adequately perform brainstem reflex testing or perfusion scans and feel they are not confounded by the drug. And there have been cases reported to me by colleagues where the only reason that the patient remained intubated for a few extra days to wake up was because they were waiting on the confirmatory levels to return.
Yeah.
So there might actually be some utility in sending off levels or concentrations just to confirm that they're no longer in the system, or at least at therapeutic levels.
Sure.
And while it may delay care by a few days, it could potentially grant a lifetime of days.
Yeah.
Abstract 6. Acute thiamine deficiency is a complication of insulin euglycemic therapy for an amlodipine overdose.
All right, so this is a case, looks like out of Ontario, from Dr. Ostina and Meritab, case of a patient who developed a hyperlactatemia after 11 days of high-dose insulin, thought to be due to a thiamine deficiency from glucose overutilization.
Right. Pretty easy.
Pretty easy, yeah. That's really straightforward. And so this is that's interesting. I would love to know more detail, and I certainly don't want to pull out the clause before I actually know the meat of the case. But I will say, and I believe actually there's some folks amongst our colleagues who are starting to look at the question of, can you precipitate a Wernicke's encephalopathy due to the administration of dextrose prior to the repletion of thiamine? And so I look at this, and my gut reaction is I would want to know a lot more detail, because to look at that old paradigm that is based on a lot of very old case reports of folks who got a lot of dextrose and absolutely no thiamine, those who were dealing with alcoholic ketoacidosis and things to that effect. So patients who were profoundly malnourished, patients who got, it sounds like, fairly substandard care in that they didn't have other nutrients repleted, and developed ultimately a thiamine depletion in the setting of prolonged dextrose use. And I believe that is where that paradigm really originates from. Mechanistically, is it possible that thiamine deficiency can lead to hyperlactatemia, and that the prolonged use of insulin and dextrose could drive that? Sure, that makes sense. But there's, if you're on, insulin and dextrose for an amlodipine overdose in the first place, I think there's a lot of reasons to have a hyperlactatemia. So again, I want to not go too far off the ledge with conclusions about this, but I would wonder a lot of details before attributing it definitively to the thiamine deficiency.
So I completely agree, and I have a couple more details for you.
I love that.
It was a 15-year-old female who weighed about 50 kilos, and she was on high-dose insulin for approximately 10 days, as well as norepinephrine. And it looks like she had a lot of other problems as well. She developed acute respiratory distress syndrome. She needed prone positioning for hypoxemia on day 2. On day 11, her serum lactate peaked to 11.4, but it had been running between 2 and 8 prior to that. So it wasn't like it was 0 the whole time. After that happened, they did an echo that actually showed she was hyperdynamic. I don't remember what this was, an amlodipine overdose once again. Okay. They did an echo, showed that she actually was hyperdynamic in her cardiac activity, and decided she didn't need insulin and dextrose anymore. That's pretty great. On day 12 of admission, they decided maybe she was acutely thiamine deficient because she had persistent lactatemia even after all these things had been turned off. She received 100 milligrams of IV thiamine with a decrease in her serum lactate from 11 to 7.7. And they started thiamine replacement therapy with 250 milligrams IV 3 times a day, and her lactate normalized after 2 days. So I agree, she definitely had other potential confounding factors, but it is interesting that they turned off the insulin, gave thiamine, and it went down. And it kind of just, I think it's a sneaky thing I never really would have had on my radar, and I appreciate that this at least threw it on there in terms of association. maybe, obviously you're going to rule out other nosocomial problems that are going to bump your lactate on day 11, but this would definitely be something to think about. Is it possible? I don't know if this is a causation, but I think it's an interesting mechanism.
Be interesting to know like what other risk factors the patient potentially had for thiamine deficiency. With her being 15 years old, in 50 kilos, was there a component of like anorexia or bulimia that may have put her at greater risk, coupled with the critical illness from the overdose, and then getting the glucose as part of the high dose insulin therapy? Maybe those factors altogether is what contributed to it, rather than it just being the glucose content from the high dose insulin therapy.
This is a very fascinating conversation, but amlodipine rears its ugly head again. Feels like the theme for today. But it would be nice to have a little bit more information on, because essentially acute wet beriberi is what they're saying. And I'd like a little bit more of like the clinical description of other signs besides just the lactate that they're associating with that. As we've kind of discussed a lot, on amlodipine, it's going to cause that vasoplegic shock. And is that contributing to some of this?
It's definitely interesting, but I'll tell you, my simple brain really likes that this could be the cause. I mean, what's the harm of one dose of thiamine?
If more people are getting more thiamine, I think the world's a better place. So,
yeah.
I'm hesitant to buy into this full-throatedly, but thiamine's a pretty friendly medication.
It's in. It's snuck into my differential there. It's there and it's planted, and I'm going to need someone to disprove it now.
I feel like all four of us are drawing the Krebs cycle in our head right now.
Right.
And the pharmacist in me is like, I know there's no evidence-based thiamine kind of dosing scheme that we would do, but they were only doing, I believe it was 200 milligrams of thiamine. And I was like, was this during the thiamine shortage so that they couldn't do the full 500 milligrams
right,
IV? And this was one of their, drug shortage action plan solutions that was put into place.
Yeah. It wasn't very much. But either way, an interesting potential novel side effect as we continue to utilize or high-dose insulin euglycemia at higher doses and longer times, something that maybe we should just keep an eye out. Look for more signal.
Abstract 7. Challenges in diagnosing an environmental cause of recurrent methemoglobinemia.
So this was Dr. Leanne Cook and Michael Levine from the Department of Emergency Medicine at UCLA. The case report was of a chronic methemoglobinemia in a patient who actually had environmental testing done and found low levels of nitrites within their water. But they then supposedly ran their dishwasher and retested their water a few months later as they had recurrent methemoglobinemia, and the levels were like 30 or maybe 300-fold higher. I actually can't remember. So I thought this was one of those a case with terrifying clinical implications, because oftentimes, I know we have had cases of chronic methemoglobinemia that we're working up for dapsone slow acetylators and what's in your water and do you have herbicides at home and all this. I think a lot of times we rely on a single potential environmental test, and it appears in this case, with repeat testing during different circumstances when different appliances were running, we had widely variable results. So I don't know, did you guys ever run into anything chronic methemoglobinemia and they end up with kind of a big environmental workup?
I feel like usually the lens starts to point toward the patient a little bit more than the environment. When this happens, you start to look for genetic causes. And I don't know if it's kind of a standard process for these recurrent or chronic folks to get things like NADH, cytochrome B5 reductase deficiencies and things to that effect. But that in my mind is where the lens typically lands in kind of conjunction with folks taking a broad look at the environment. I've certainly had a few cases where it's just a very unsatisfying ending. And we think, wow, we just kind of came up empty and they're feeling better. Great. But to your point, Ryan, if it can change this much, temporally, then it's certainly worth taking a fresh look each time the lab comes back abnormal, because I think it's an impressive finding and something that maybe changes kind of how you would approach these rebound cases.
Yeah, I think for me, it's just maybe we need to test twice, run the dishwasher. I don't know. That's pretty fascinating.
The question is, who do you reach out to do all this environmental workup? With lead, most of our states have pretty robust environmental testing systems in place. And these situations, I can call the Department of Public Health, but do we have the resources or any kind of infrastructure to do serial testing of however many samples they need from every water source? It's a fascinating question to have. I'm glad that they came up. It's a fascinating case because very smart people figured this out. I don't know how I would be able to change it in my state's infrastructure.
I'm going to give the credit to the patient here because they actually bought home test kits, and I think they said there's no way this is negative, and because they showed up with methemoglobin levels of greater than 30% multiple times, and ended up needing it. So there are at least right. We're in a similar boat. We have little control over the resources that can be mobilized for something like this. But patients, there are a lot of home testing kits now for water and other things. And I guess it's going to have to be, sometimes it falls on them, unfortunately, in our system to decide how much they want to invest here.
I would love to see patients like this in our tox clinic. This would be the perfect patient to have at the tox.
Highly motivated.
Highly motivated, very well thought out.
Case series, levels before and after, dishwasher run cycles, and if it came from the tap on the first floor, second floor, all of that.
That's a good NACCT study next year. My own personal nitrite distribution throughout my home with and without appliances running.
Ryan, the one that I want you to kind of touch on is your group's iron study. Essentially,
let's jump right into that.
Category 4. Comparative evidence, prognostication, and triage. Abstract 8. Utility of pre-4-hour iron concentration in predicting toxicity.
Am I allowed to read this one myself, or is that a conflict? So this is a study that we did, myself, Dr. Jill Theobald, who's our associate director of the Poison Center, as well as our 2 PGY2 pharmacy residents.
Ryan forgot to mention that those residents' names are Dr. Abigail Sharp and Dr. Haley Fox.
And my colleague, Matt Stanton at the Poison Center. And we were trying to figure out the utility of a pre-4-hour iron level in predicting toxicity. To give some clinical context, and I want to ask you guys before I dive into this. So iron traditionally is said to be absorbed within 4 to 6 hours. So it actually has a little bit of a longer absorptive time than many of our drugs, where we say usually within 2 to 4 hours, right? But iron kind of goes through active transport. The body tightly regulates it. So it's absorbed a little later. So for quite a while, our practice was to check a 4-hour level and to make sure we were looking at quote unquote peak absorption, and then to check an 8-hour level to make sure we knew which direction it was going. But we were running into all of these patients who would show up in the emergency department, and the shotgun kind of fast thinking move was, oh, they took iron, let's check iron. And now I have a 2-hour iron level, and I don't really know what to do with that. So we have all this excess data. Is there some way that we can weaponize it in prognosticating for toxicology? So that was sort of the impetus of our study. Before I go into it, in terms of each of your practices or throughout training, did you have any special timing for when you would check iron levels in an acute overdose or acute ingestion? I feel like you hear a little bit different everywhere.
We would always do the 6-hour. Now, if the patient was showing systemic signs of toxicity, like they were already having hypotension, those are going to be cases that we were going to probably treat with DFO anyway, and would utilize the earlier iron levels to, make the case that, well, if it's already causing hypotension and the level is greater than, 350 now, in 2 hours, 3 hours, it's probably still going to be elevated, or to the point that we'd still be giving antidote and give the antidote. But for our cases that present early and haven't had any symptoms, or maybe only had minimal GI distress, those are cases that we'd always say, oh, we're going to get another level at 6 hours before we make a decision on deferoxamine therapy.
Between training in Chicago and then Minnesota and Iowa, I feel like all places had a little bit of differences of how they did it. So I still am trying to get my finger on the pulse of exactly every single time doing the same thing. Most of the time, as you alluded to, Ryan, the whole purpose of the study, or how you guys had this data, was that a lot of times I have an iron level before I'm even called, and that ends up being at 2 to 3 hours or whatever. And in where I practice, we actually determine this level of care. So we determine if a patient goes to the floor versus ICU versus home versus anything. And so, if someone has iron deficiency anemia, and they have a 3-hour level that they're still iron deficient on their iron panel, I can probably start working towards a floor bed versus at 3-hour level. They're getting close to that DFO kind of cut off. But I still do similar to what Natalia said, that I get them past 6, 8, 10 hours kind of with repeat. And every case is a little different on the nuance of how, if they're drastically going up or not.
Yeah, and fairly consistent from Rocky Mountain Poison. We want to get at least something 6 hours or post, and then at least a couple of data points to demonstrate a fairly steady trend, especially if we're approaching that 500 cutoff, or if the patients really have prominent GI symptoms, which they all do. But if there's anything that's making even semi-borderline, then a couple of data points is the big thing. But certainly looking 6 hours in post.
Right. So I'm hearing later levels, obviously clinical symptoms will guide therapy faster, but generally we're waiting for that full absorption. So we were trying to figure out, could we do anything with these earlier levels? And we looked at patients who had 2 iron concentrations. One had to be before 4 hours. So your standard, hey, they show up, they get an iron level, and we say, well, I don't know what to do with that yet, so get another one. And we basically plotted their initial iron level and then evaluated whether the patient ended up needing deferoxamine for any reason. So they had serious symptoms, or they had a level of greater than 350 and some symptoms, or they had an asymptomatic level of 500. Those are generally the people who got deferoxamine, because those were people who were worried we're going to go up pretty high. And we evaluated whether or not their pre-4-hour level could predict whether they were going to develop symptoms or need deferoxamine. And what we found was a pre-4-hour iron level of less than 300 mics per deciliter in both our intentional overdoses and our unintentional overdoses had a 100% negative predictive value for needing antidotal therapy with deferoxamine. So these patients weren't going to end up getting chelated if you were below 300 before 4 hours. The average time it took for our patients to peak, as it would be, was about 181 minutes. Now recognize we didn't have control over when the labs were drawn, so that's not an exact peak. That was when we were seeing our peak level. It was a little bit longer in the intentional group, 240 minutes. So that's about 4 hours or so. But if there was an anticholinergic ingested with it, I actually loved this. This is kind of proof of concept that our gastric motility slowing agents really do delay absorption. Our peak time was 551 minutes. So we did see delayed absorption, although actually our peaks were happening pretty quick, it looked like. So kind of our takeaways from this were that, yeah, peak absorption can be longer than 4 hours, especially if there's an anticholinergic involved. But in this data series, if you were going to develop toxicity, you were going to hit a level of above 300 within the first 4 hours. And the range here was about 30 minutes to 4 hours, although it was more within the 2 to 4 hour range. How I use this data personally, I'm still uncomfortable with a single time point because it's not where you are, it's where you're going, right? So, but I do think using the combination of the initial, shotgun iron that gets drawn by whoever's seeing the patient with a second level, within before 4 hours even, kind of makes me feel more comfortable in saying this patient's not going to develop serious symptoms. So if I have a level of, 150 right away, and the next one is 250 at 4 hours, I might be, less concerned that they're really going to develop any symptoms, despite them not being at that 6 hour level. So yeah, I thought it was kind of interesting. Go ahead, tear it apart.
No tearing to be done. It's super interesting, Ryan. A couple of questions come to mind. And the first one is, this is a single center. It's 5 years. And I think back on my fellowship experience, and I gave DFO, a couple of times, not a ton. And that's with a fairly big poison center. And so my first question is, how many patients got sick enough to need DFO, period? And kind of, is there some degree of sample size bias, whereas if nobody gets DFO, period, over the course of 5 years, which I'm sure is not the case, but if nobody gets it for, over 5 years, well, then your negative predictive value is 100%. And so I think it's super important to know how sick this population was. I think it'd be incredibly helpful to have some general sense. I mean, this number is always so wishy-washy, but to have a general sense of mg per kg for what the ingestion was, to be able to kind of stratify in your mind of how bad you're expecting them to get in the first place. But really, the main question I want to know is how much DFO is being given, and does this really help to differentiate the sick from the not sick, or are we just looking at a generally not sick population?
Right. And that's a great question. 132 patients included. 93 of these were intentional ingestion. And that's really, I have never really seen an unintentional iron get very sick. They usually get a couple of tablets and they're okay. So I really care about, what pops into my head. It's usually an adolescent female who took, a large amount of OTC iron that they had in the home in a self-harm attempt. So we had 93 intentional ingestions. Deferoxamine was used to treat 6 patients. So it's about, 7.5%, something like that, attack rate of, iron greater than 500 or severe symptoms. So absolutely, like you said, it is, just because by the nature of ingestions in general, I think many of them don't end up with severe symptoms. We have like a 1% mortality rate in all of poisonings overall. But actually, I was sort of surprised to see that we used DFO 6 times in that year. We were using it once a year. Kind of interesting. So some people did develop toxicity. Is that a massive sample? No, maybe we need a collaborative between a couple of different sites to really say we have enough sensitivity in terms of our population. Because we could probably do a sensitivity calculation here to see the 95% confidence interval on that. And it might change a little bit. It is somewhat, I agree. I don't know that it's 100% there with the smaller sample size.
I think it would be great too to look at it in an adult patient population. In my experience at like Boston Medical Center, and a lot from my fellowship, it was primarily a pediatric adolescent population. And in those cases, they're going to spend more time in the ED anyway, because you're getting social services involved. So for them, getting a 6-hour level, it's no big deal, because the patient's going to be there anyway. But in our adult EDs, where having the patient need to stay an extra 2 hours, needing about an hour for that left turnaround, that 3 extra hours could make a big difference in times of high ED boarding, which I think is everywhere these days. So I would like to see this done in a primarily adult ED population, and like others have already said, collaborating with other centers to try to have it have larger numbers and potentially sicker iron overdoses.
Yeah, I feel like this is ripe for a multi-center study, whether that's toxic or NPDS, or just regional poison centers all kind of getting together and pulling their data and seeing how we can use a power calculation or whatever we need. It's fascinating work. And I'm actually, when I saw this, I just keep thinking about this, like, is this ready for prime time? And I like it a lot. I feel like a secondary study with a little bit more patients, maybe there, but not yet, but close.
Agree. I don't know if it's prime time, but it's one of those things where when there's no data, kind of fuzzy data tends to occupy that part of your mind. And then when you get that really borderline patient that your gestalt says, I think they're going to do okay, and there was that one bad study that showed, and you're kind of like, well, maybe they'll be okay. They could go home early. But yes, I agree. More data should probably be used.
Abstract 9. Andexanet alpha versus 4-factor prothrombin complex concentrate for intracranial hemorrhage at a level 1 trauma hospital.
One question. Is Andexanet alpha on formulary?
Yes, but it will not be given, because our ED pharmacists are brilliant human beings, and their entire job in that situation is to say no.
It's a no-go. I love it.
We have not added it to our formulary either. So it's always fun when our very small community hospitals send the patient in on Andexa for their head bleeds, and then our neurology department is like, we need to figure out how to continue this. And MedFlight is like, but we need to leave with our pump. And it's like, well, we need to get every last drop out of that tubing before you can leave.
That's fantastic. Did they have it in Colorado?
Yeah, we had it. Inter-individual enthusiasm about it. Some folks who would rally behind the cause, and some folks who would put the kibosh.
So this was a retrospective review of all patients who received 4-factor PCC or Indexa for an ICH while being treated with a factor 10 inhibitor over a 6-year time frame. Also done by colleagues in Minnesota. Their primary outcomes included good or excellent hemostatic effectiveness based on ICH volume change on head CT, and good functional outcome based on a Glasgow outcome score greater than 3 at discharge. Our radiologists were blinded to reversal agents for each patient, and they were the ones to calculate the hemorrhage volume before and after reversal. Secondary outcomes included things like hospital length of stay, incidence of thrombosis, discharge location, cost, and drug concentrations. The authors found no difference in hemostatic effectiveness or good outcomes when either 4-factor PCC or Indexa were used for apixaban or rivaroxaban related ICHs at this level 1 trauma center. When patients received Indexa, the median cost per patient was $28,000 higher than when they received 4-factor PCC.
That was pretty much the big tagline for me. I think this study did a lot of things right. This was really beautifully done. They looked at patient-specific outcomes, clinical surrogate outcomes that we use to choose therapies. So they looked at intracranial hemorrhage volume expansion. They looked at neurologic outcomes at discharge, and they blinded a radiologist to do the calculations on these things. I think that was really smart of them. And guess what? There was no difference in hemostatic effectiveness or functional outcome, regardless of whether you use 4-factor PCC or Indexnet alpha. The only difference was the hospital bill that you're giving to that patient. And that, I think, was a really well done thing. My favorite part about this study was that the poster for this was right next to the Indexa booth at the conference. Yeah.
Well, the FDA is requiring them to compare their drug versus PCC. So this is probably the first of what will be a much larger and ideally randomized study to answer definitively, is one better than the other? But I think right now, for many institutions that chose not to bring Indexa to formulary, this helps to support their decision in using 4-factor PCC as the primary reversal agent for our rivaroxaban and apixaban.
You guys have Indexnet not on formulary?
Not on formulary. We had a multidisciplinary discussion that involved our neurocritical care, neurosurgery, critical care, hematologists, and our anti-thrombotic task force, where we really reviewed what's the currently available literature besides cost. What are the potential benefits of bringing it on versus what are the harms? And especially as a safety net, hospital, we didn't, in our opinion, there wasn't enough data, especially in terms of patient outcomes with like length of stay or better functional outcomes at, discharge to justify what could be a $60,000, per patient expenditure. We elected at the time to say we'll continue to review this roughly every 6 months to a year as new data comes out. So far, we have elected not to add it to formulary and have been fortunate that other institutions have added it to formulary and are doing, research like this to compare outcomes with, 4-factor PCC to help us have, better data to either, justify or to change our Indexa practice at Boston Medical Center.
I think this is super useful data. We have it on formulary, but its use is pretty infrequent. I thankfully have never had to use it and generally opt for PCC given the fact that there is no proven benefit and all it does is increase the patient's cost. So cost-effective evidence-based medicine would dictate other therapies. Very interesting, the authors of this paper, I know, had it removed from their formulary, potentially due to this evidence, which I think was really great.
Just out of curiosity, at your institution, do you have any specific restrictions for it? Because when I think of our ICHs, probably close to 70% of ours are from rivaroxaban or apixaban. And right now we're using just PCC for that. So if we did have Indexa, on formulary, it'd be interesting to know if others have implemented like a tiered approach to only apixaban or rivaroxaban ICHs with certain criteria can get Indexa, or you have to fail PCC to then get Indexa.
We do have criteria. It's the same exclusion criteria that was used in the original Nexa 4 trial. So you need to have a GCS that is greater than 7. You need to have a potential likelihood of a good neurologic outcome, no immediate OR in the next 12 hours. There's really a lot of stipulations which red tape it and make it pretty hard to use. But I think that does limit it to the population in which there was some sort of, not even necessarily a clinical benefit, or at least a comparative clinical benefit, but a benefit seen in the study. So I think it's judicious use of a resource. We did a study looking at PCC in warfarin-related intracranial hemorrhage, looking at time to administration. And at the end of the day, what we found was that whether you got Kcentra in 30 minutes or 2 hours, it didn't make a difference in your neurologic outcome. And I always wonder just how much does the reversal even affect the overall outcome? Sometimes this train is already on its way, and we're putting our medication resources into it because it's all we can, but it's putting a pillow in front of a train and hoping it'll stop it, and it doesn't always do it. Well, I think this was a great review. I think we got through really some of the most important abstracts that I saw out there that I found relevant to my practice and hopefully to others who are listening. And I hope this was at least a fun review if you didn't get to peruse through all the abstracts. I'd like to thank my guests today, Dr. Grant Comstock, Dr. Dan McCabe, and Dr. Natalia Farrell. Thank you for joining us today.
This is fantastic. Thank you for having me.
Yeah, this is a lot of fun, Ryan. We appreciate you.
Yeah, no, thank you so much for inviting all of us to participate in this. I do think that we get a lot of really good content at NACCT, and the abstracts presented have so much of a wider reach. So I think your podcast would be a great way to share with the community and hopefully, trigger some, research ideas for others so that we'll have even more data out there to help us with, answering so many of these great questions.
I can only hope. Hey everybody, we had limited time with the guests, but fortunately, you have unlimited time with me. There was a few extra abstracts that I did want to run through because I thought they would be relevant to people's practice.
Abstract 10. Fentanyl and fentanyl analog exposure among emergency personnel and first responders. A systematic review.
Well, maybe this one's not that clinically impactful, but how could I pass this one up? This was essentially a systematic review of case reports of fentanyl or fentanyl analog exposures, and they found that no emergency medical services had clinically important symptoms from exposure. What is very interesting is they were actually able to detect fentanyl in certain reports from forensic laboratory technicians. So while clinical intoxication was rare, first responders may experience subclinical exposure to fentanyl and fentanyl analogs when inadequate PPE is used. And in fact, inadequate PPE was a common theme. First responders should still employ basic PPE to minimize fentanyl exposure. The long and short, lab techs chronically working with fentanyl had detectable levels, but that's not that important because there were not any symptoms. Subclinical exposure does occur, but symptoms don't.
Abstract 11. Significance of falsely low creatinine values in diagnosing massive acetaminophen ingestion.
This next case report is from Aaron Guina from University of Manitoba, Winnipeg in Canada. This was a case report of a falsely low creatinine from a Tylenol overdose. It measured at 0.08 milligrams per deciliter. The reasoning for this was an interference with the Trinder reaction, which is sometimes used to measure creatinine. NACCT as well as NACCT inhibit the Trinder reaction. So it's possible that both NACCT and NACCT may have interfered with the assay. The actual Trinder reaction is when hydrogen peroxide and 4-aminophenazone combine to form a colored product. This is the last step in many enzymatic creatinine methods. So any analysis using the Trinder reaction is impacted by both NACCT and potentially NACCT. Other labs that might use the Trinder reaction include cholesterol, triglycerides, lactate, lipase, and uric acid. Of course, not all laboratories are going to be using this method to measure creatinine. But if you see a very large acetaminophen level and a very low creatinine level, it might be indicative that NACCT is already being produced. Maybe talk with your lab to find out what kind of assay they're using to measure their creatinine and see if this could interfere with other labs as well. The next abstract I wanted to discuss is by Kevin Osterholt from Children's Hospital of Philadelphia.
Abstract 12. Large dose intentional ciprofloxacin and ingestion associated with false positive urine immunoassay for oxycodone and fentanyl.
There's another list of substances to add to your differential for a false positive for fentanyl, which for me is currently only risperidone, but I'm sure there's others.
Abstract 13. Don't make it a double. A 20-year review of supratherapeutic amlodipine ingestions while on chronic therapy.
Here's one from the Georgia Poison Center group. This was a retrospective review of amlodipine therapeutic errors in patients on chronic therapy. Something we run into in the Poison Center world, where somebody is taking one of these medicines and they double up on their dose. And some of these medicines which can lower your blood pressure, we can run into problems. So who gets to stay home and who doesn't? They looked at 268 patients who ingested a known quantity of amlodipine and were followed to a known outcome. That's pretty important because sometimes poison centers will just assume you're going to be okay and check out if it's low enough risk. So none of those cases were included in the study. Only people we know did well. Of those who were treated in a healthcare facility and ingested 20 milligrams or less, only 50% experienced symptoms. And the symptoms were generally minor or moderate. Of those who experienced moderate effects, only 3, or 1% of all cases, were single-agent ingestions. And in all of those moderate effect cases with less than 20 milligrams, none of the effects could even be attributed to amlodipine. The long and short of this study, a double dose that is less than 20 milligrams is unlikely to need healthcare evaluation.
Abstract 14. Evaluation of pediatric lisdexamphetamine exposures reported to a statewide poison control system.
This one's from Justin Lewis, Abigail Takis, and Ruxin Shib from UC San Francisco and the California Poison Control System. They looked at lisdexamphetamine exposures, essentially trying to answer when a kiddo gets into somebody's Vyvanse, when do they need to go to the hospital? They looked at only patients who weren't taking these medications regularly, so naive patients, and they evaluated the outcomes from those patients that were referred into the hospital. So all of these patients were actually observed in the emergency department for 4 hours. They also excluded anyone who got charcoal because you wouldn't be able to get that at home. They ended up with a total of 20 patients who were referred to the emergency department for lisdexamphetamine exposure. 30% of the patients had no effects whatsoever, and the doses reported in the no effect group ranged from 20 to 50 milligrams, or 0.7 to 2.7 mg per kilo. But I'll take that with a grain of salt. This is Poison Center data, and it's possible those children weren't exposed to anything at all, which could be why they developed no symptoms. The other 70% of patients did develop symptoms, and the lowest dose to cause symptoms in a stimulant-naive patient was 1.1 milligrams per kilo. It produced a mild tachycardia and hyperalertness, which resolved without intervention. So 1.1 milligram per kilo or less might be okay to home manage. Symptoms that do develop with that dose appear to be mild and resolve without intervention. So as long as there's good monitoring at home, not necessarily a reason to go to the emergency department, though obviously that decision should be made in conjunction with a poison center. And 1.1 milligram per kilo is not a hard dose to reach, given that many of these are in 20, 30, 40, or 60 milligram capsules, and children often weigh less than 20 kilos.
Abstract 15. An assessment of the reliability of stated quantity in acute acetaminophen overdoses reported to a regional poison center.
One of the final studies I wanted to talk about was a study by Nicholas Husick, Jimmy Leonard, and Angela Lamb in Maryland. This was a pretty bright study. An assessment of the reliability of stated quantity in acute acetaminophen overdoses reported to a regional poison center. They actually looked at patients presenting for acetaminophen overdose and did 2-point kinetics to back calculate the dose a patient would have taken based on the elimination half-life calculated from their 2-point elimination rate constant. They looked at the stated dose of acetaminophen in acute overdose versus what it calculated to. And they found that in 8% of cases, the stated dose accurately predicted the level. Or in other words, 92% of patients were lying. About 54% of patients had concentrations greater than what they should have been for the dose that they supplied, and about 38% had concentrations lower than what they should be for the dose that was reported. Now, I do think there's a lot of limitations in this. When we take drugs in overdose, there's the potential for continued absorption. And if you are eliminating faster than you're absorbing, you'll see a net decline in your concentration, but it'll appear as though your elimination rate is slower than it actually is because it's incorporating both continued absorption and elimination. This would create a falsely prolonged half-life, which would interfere with the dose you would back calculate the patient to have taken. Additionally, in first-order elimination, you have exponential elimination of the drug, meaning you have the most elimination occurring right away when the most amount of drug is present. So if the 2 points you use to calculate your elimination rate constant are very near each other, you might create a linear slope that is way steeper or overestimates your elimination rate constant compared to taking 2 points that are very far from each other. I think this is probably confusing a lot of people, but the point is there's a lot of limitations in doing PK calculations of 2-point kinetics, particularly in patients where you don't actually know what dose they took, so you can't back calculate a lot of the variables that you can use for their kinetics, like volume of distribution. A number of variables have to be assumed, like the bioavailability and the volume of distribution, and there can be variability in the elimination rate constant that you get depending on which concentrations you use to calculate your variables, as well as some unique things that can occur when taking large quantities of drugs. Either way, I thought this was a really clever study, and if even a kernel of it is true, it supports what a lot of us already know. Patients are often incorrect or intentionally might mislead about the amount of drug they ingested. Well, I think that's going to do for the rest of our abstract review. Thanks for listening along with us today, and I hope we were able to provide some clinical context into the findings of these very important research. The toxicology community has an impressive output of meaningful research each year, and it can be difficult to stay on top of things. So I hope this high-yield review of some important abstracts helps you stay engaged and able to care for your patient. Huge thanks to my guests today, Dr. Comstock, Dr. McCabe, and Dr. Farrell. If you like what you've been listening to, please give us a review wherever you're listening to podcasts. It helps us reach other people interested in learning about toxicology. You can follow the show on Twitter at LabPoison, myself at EMPoisonPharmD, on Instagram at Tox_talk, Facebook, The Poison Lab, or just go to our website, www.thepoisonlab.com. All of those resources will let you know when we're releasing new episodes about toxicology subjects with experts in the field of toxicology. Always free and always for you. Hope you can tune in next time. Hey, Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio, mate.